This is Mladen Jovanović from Complementary Training.net, and in this interview I'm talking with a friend of mine, Žarko Vučković. He's a general surgeon at Aspetar Orthopedic Hospital in Doha, Qatar. I've taken some of his time to chat about some general things about injuries, especially groin injury and sport hernia. Thanks for your time and welcome to let's call it a podcast.
Thanks for inviting me. It's a pleasure.
So let's quickly introduce yourself to the listeners. How long have you been working in Qatar, and how did you end up there?
Hi to everyone. As Mladen said, I'm a general surgeon. I used to work in a general hospital here in Belgrade, Serbia, until 2007, and I was also involved in sports as I was a doctor of national teams of team physician of national teams of handball Serbia, and because of my love of sports and my interest, I worked there for 5-6 years. And at one point I was invited to be the national team physician of Qatar volleyball national team in 2007, and I wanted to see what is this new challenge, and I ended up in Qatar. Then as soon as I arrived, I saw Aspetar Hospital, and which was a dream come true for every doctor who would like to work in sports medicine and sports surgery. And finally, after a few years, I ended up working there, subspecializing in groin pain in athletes. And this is solely my field of interest in the last 5-6 years.
So how long have you been in Qatar?
8 years will be now in November altogether.
And in Aspetar?
In Aspetar, since 2009, 6 years.
Yeah, can you explain a little bit about the Aspetar model, if there is any? How is it similar and different compared to other systems of treating sport injuries?
I would say that this is almost a unique system. In what terms? There are probably, but not too many, similar hospitals in the world treating athletes, covering all aspects from sports medicine, sports orthopedics, and sports physiotherapy, including also sports science and research. But the unique thing about Qatar is that we have, about Aspetar, that we have also the National Sports Medicine Program, because the hospital is funded by Qatari government. And also all the sports teams are under the, under the sponsorship of Qatar Olympic Committee, and which is closely related to Aspire Zone and Aspetar Hospital. So we have the National Sports Medicine Program, which means we employ all the doctors and physiotherapists who are even fitness coaches for junior teams who are working in sports teams in Qatar and national teams also. So what does that bring us? We have almost full control of all healthcare in sports in Qatar. So all the athletes, they get treated at the end in Aspetar or in their clubs in Aspetar staff. So it's very easy to, if you want to do some research, you can get easier access to data, and you have a better follow-up. And I think it's a pretty unique system. And also it ensures that all the healthcare professionals in the clubs and federations are not so much under pressure of the team management per se, because they also have full support from Aspetar Hospital, and this is their employer, so they can do their job, of course, in the interest of clubs, because it is sports medicine, which is different from general life, but they can do their job in the best interest of athletes.
So it's also easier to do ongoing screening and educate the staff.
All athletes from Qatar, and especially football teams, because of course football is the most important sport in the world. All athletes go through yearly screening in Aspetar.
Yeah, we're going to talk more about the screen protocol, but let's talk about your specialty, the sport hernia and adductor injuries, and the umbrella term that's usually thrown around, groin-related pain. How did you end up specializing in that area, and can you explain what are the just tell us a bit about your experience in those 2 or 3 categories and mechanism of injuries.
Okay, I ended up specializing in groin pain because as a general surgeon, the most prevalent surgery for groin pain is a type of hernia repair, which is what general surgeons usually do. There are also some surgeries done on the adductor muscles, which are more in the field of orthopedic surgeons, but not so often. And we have in groin pain, per se, like you said, the preferred umbrella term is groin-related pain, which is since November last year we had a consensus meeting in Doha, Qatar, where we had 22 experts from all over the world who contributed to a paper where the main author was my dear friend Adam Weir, and 18 were on the spot together at one point discussing all day about terminology in groin pain, because this is the first step for comparing results and to ensure that we're all talking in the same language, so not to compare apples and oranges. So,
exactly.
So we came to the conclusion that our preferred term is sports groin-related pain, and then it can be inguinal-related groin. So we have 3 main groups. One group is inguinal-related groin pain, adductor-related groin pain, iliopsoas-related groin pain, and pubic-related groin pain. Then the other group would be hip-related groin pain, and then the third group would be all the other causes of groin pain, which are not usually considered when you talk about groin pain, like different fractures, intra-abdominal, gynecological, urological abnormalities, etc. So this would be general medicine. This is not what we talk about when we say groin pain. There's a lot of prevalence of hip problems, and it has been proven that especially now the children specialize earlier, that if children start, for example, playing football at younger age, before 12, to train daily and to specialize in one sport, there's a much more bigger incidence of FIA, femoral acetabular impingement, which can cause different hip problems. But when it comes to groin pain, what we usually mean, it's mostly, as there was one paper by Professor Holmich, who is also the lead of our groin pain center in Aspetar, based basically in Denmark, in Copenhagen. He had a paper about entities, and where they defined that the most prevalent is adductor-related groin pain. It's like 60-70% of people. Then it would be like 15% of people have iliopsoas-related pain, and in their paper 5% have inguinal-related groin pain. That may be related to his specialty, because he's an orthopedic surgeon, and probably people with inguinal pain go more to general surgeons and not to an office of an orthopedic surgeon. But what we came to a conclusion that usually we have inguinal and adductor pain that are overlapping, and it depends which is the main pain, which is the thing that is causing more problems. But why you have overlapping? It is because that lateral abdominal muscles, where you have 3 layers, external oblique, internal oblique, and transversus, their point of insertion, is at the pubic bone and over the pubic bone, and the fibers intersect with the adductor fibers. So basically it's like a continuum of the fascia going from the external oblique and internal transversus conjoint tendon towards the adductor muscles. Also you have a rectus muscle coming to the pubic bone, where these muscles join the rectus and then connect with the adductors. So it's always the balance between the adductors and the abdominal muscles. And in the 60s, to be precise, in 1967, the first surgical treatment, inguinal surgery for groin pain, was done by a Serbian surgeon, Dr. Nešović, who was a football player himself and a doctor of the Red Star Football Club. He operated on a Red Star player who had groin pain, and he had this idea that the adductors were very strong and the inguinal and the abdominal wall, inguinal canal, was needed to be reinforced because the abdominals at that time were not focus of training and they were weaker. So he did a hernia type Bassini repair, and the player recovered, and he started doing these surgeries more and more, operated players from Real Madrid, etc. Later on. So he discovered that there is a connection between the inguinal canal and the adductors, and that the abdominal muscles were weaker than the adductors, and that's why you need to reinforce this compared to doing the adductor tenotomy, weakening the adductors because there's too much tension on the pubic bone from the adductors. So since then there hasn't been a huge improvement because you have a lot of people doing surgeries on athletes, different types of inguinal repairs, which can be open or laparoscopic. Open can be with mesh or without a mesh. Laparoscopic is always with mesh, and different theories for pain. But what you can see is that a lot of people are only focused on their field of interest. So if you have general surgeon, they operate on the inguinal canal, and this is what they know from pathology side. If you talk with some expert physiotherapists or orthopedic surgeons, they're more focused on hip or on the adductors. And nowadays it's more and more recognized that iliopsoas can be a contributing factor for groin pain. And from my experience, I would say that it is usually, if it's primary, it is in long distance runners and straight line running with a large number of repetitions. But even in football players and other sports, iliopsoas is very often involved because it's a major stabilizer of the pelvis. So once you start having adductor or inguinal pain, I think iliopsoas is trying to protect them, and there is an overuse of the iliopsoas.
One quick question is, I think recently they've been questioning the term iliopsoas, just saying that they are actually not a single muscle, but two muscles, yes. And they might be innervated differently as well. Mm-hmm. They might have same insertion, but they function as two different muscles. So is that what's your opinion about
My opinion is that it is, when I see that there is iliopsoas injury, that if it's just overuse and if they have rest from sport and they have physiotherapy exercise program for the other structures, that usually this settles down. But if it's a primary injury, the iliopsoas, it's very difficult to treat. And because of like you mentioned, there are two muscles. It's the iliacus muscle and the psoas muscle, yeah. Coming from two different sites, and they just insert together like in one tendon. But radiologists would see that there are different tendons on the insertion. I don't think. Well, in clinical examination, of course, you cannot define is it psoas or iliacus more injured when it comes to a tendon. But sometimes you can get some psoas tenderness when you palpate the psoas muscle through the abdominal wall, and it can be tender on a straight leg raise during the palpation. So and then you can say, okay, psoas is more involved. But there's no, until now I haven't seen that there's a rule in which cases you will find psoas involvement, in which not. During the standardized examination, this was also described from Professor Holmig's paper. You have to check the adductors, the inguinal canal, the iliopsoas muscles. There are different tests. You have the squeeze test. You have resisted hip adduction. You have resisted sit-ups. You have palpation of all the structures. It means distal rectus abdominis, pubic symphysis, pubic bones with the pubic tubercle, where the abdominal walls muscles insert, and of course from the inferior side where the adductors insert. What we can say that when you have the pain on the insertion of the muscle, it is usually more difficult to treat. And it is like all insertional tendinopathies, like when the Achilles tendon, when it's on the bone, it's more difficult to treat when it's compared to 2-3 centimeters above. But also Professor Holmig, in his papers from '99, described the exercise-based protocol for adductor-related groin pain, and in that paper they showed that you can have 80% success in between 12 and 16 weeks of exercise-based protocol. The thing is, this is a two models. One model is 2 weeks, then you have some other exercises added on, and this is something that probably can be improved because now it's been 16 years of development of fitness, of different types of training, of our knowledge in this field. But it is, a huge landmark, this paper, because the first paper that showed that you need to work because tendons don't like rest. So you need to work, and with exercise they will become better. With rest only and medication or physiotherapy with local modalities, ultrasound, laser, things like that, this doesn't help.
So just resting the muscle doesn't help. Or
the pain
muscle or tendon.
Yeah, the pain will go down, but as soon as you come back to the field, the pain will come back. So what we have a distortion of the structure of the tendon itself, and instead of having a linear, straight, parallel lines, straight structure, regular, we have like a little bit of chaotic
zigzagging, something like that.
Something like that, and that is what you need to treat with and the matrix becomes more fluid around the cells, etc. So you have to put some exercise, some load on the tendon, but control load gradually increase in order for tendon to heal. So what we saw in some cases, and it's also very difficult when it comes to highest level sport, because if you put someone into exercise program and after 3-4 months you don't have, even if it's 70-80% of success, if you have these 20-30% who don't become better, and then you have to do surgery, they feel that you already lost time after 4 months. So sometimes you have to make this decision more quickly. And for me, if you have someone who can do the exercise and you see regular progress in decreasing pain and progress in strength and the level of exercise that the patient can do, I think you're on the right track, and you have to follow daily, monitor pain and monitor the progress. But if you have someone who after 4 to 6 weeks doesn't progress and cannot perform the exercises, then you have to probably do especially if it's a long history of like 6 months to 1 year, then you probably have to do adductor tenotomy.
So basically you're suggesting before doing any operation, try to do rehab as much as possible?
Not as much as possible, but I would say because
keep tracking, and if it doesn't help,
you have to have like a specialized person who knows a lot about this type of injuries, has experience with treating athletes. And then this is because we don't have at this moment enough scientific proof for different things, but if you have experts with enough experience in this field, they can see if someone is progressing or not, and then I would never operate on anyone unless I'm sure that he had at least 4 weeks of proper physiotherapy with on a good level center. It doesn't have to be in Aspetar, but from our side, I know that we have some good physiotherapists.
That's like a safety. Yes. Say safety check or safety.
Yes. Because many times it happened a few times that I was pretty sure that somebody would need surgery, but after 4 weeks with us in physiotherapy, they would recover, and then it makes you think a little bit. And
like if you take total time that you might lose based on this, let's say, 4-week period, and talking about high-level sports where every day counts, you want to get a player back on a pitch as soon as possible. Like when you compare different strategies, say you operate immediately, then you have a rehab period, compared to let's try 4 weeks of aggressive, let's call it prehab or rehab, and then if something happens, then we operate, and then again we have return to play protocol. Speaking about, let's say, probabilities, like what's the more probable, and what's the I will say I forgot the statistic term, expected time loss.
How I see it, and like I said, I don't have strict data, and I cannot at the moment prove this scientifically, and we have a lot of work to do in this for these terms. But I would say that if you do 4 weeks of good prehabilitation before surgery, it's not a lost time, because you still have to work on all the structures that can be affected or that can contribute to treatment. So you have to rebuild all the muscles, the muscle neuromuscular control, the way of moving, biomechanics, etc. So and you know better than me, all expert fitness will say that you cannot rebuild a muscle in 2 or 3 weeks. You need time.
Yes.
3 to 6 months to have some results, some proper results in good training. So 4 weeks, let's make it simple. 4 weeks of prehab maybe adds, you have in the total lost time, if you give them 4 weeks of prehab, maybe they stay 2 weeks more after they spend then if you operated immediately, but then at least you're sure that they needed surgery. They just didn't operate.
Makes sense. Is having aggressive prehab helping with rehabilitation afterwards?
Of course.
So it can speed up. It's like preparing for ACL injury by building a quad muscle.
Exactly. If you operate immediately and then you have to rebuild muscles, maybe you need
extra time.
Maybe you need 3 months, and if you just someone can come to play earlier, and this is also something we can discuss. You can get someone back to play in 1 month, but you didn't probably correct all the imbalances that he had. Because if I go to the gym and I want to look like a high level athlete, I cannot do it in one month. Probably I won't be able in 1 year. But an athlete who is not ready, you need months to get him ready, not 4 weeks.
Exactly.
If you get someone who is not trained and you want to get him to compete in the highest level competition in 4 weeks, it's impossible. So you know better than me that this needs time. And for me, this is because I can say, a lot of passion for sports and a lot of experience working as a doctor with athletes. You need time to rebuild muscles, and this is just the crucial point where is the pain, and you can treat it with surgery. But if you don't correct all the things that led to this injury, you will have a recurrence of injury. So it means that he needs that and what I would say as the most crucial part for training, it's the core, the abdominal muscles, the back muscles, working on the right movement patterns, and on the drawing in of the abdominal wall, controlling the transversus, and this is like with biofeedback exercises. Then you have proprioceptive exercises, then gluteus medius with the adductors to be in balance, adductor and abductors. Then, like you said, of course you have to have also hamstrings and quads. Everything needs to be in balance, because all this helps that you can control the movement. You have the proper swing phase, hocking phase, swing phase, follow through, and it's not a jerky movement. It's a controlled movement. Whatever you play,
Speaking of that, what's the mechanism of the injury? Is it more acute or more chronic, or
you can have both. You can have acute or chronic. And it's different. In acute injuries, you have much more adductor injuries, especially adductor longus tears. Then when we talk about pathology, then you can have if it's insidious onset, like a chronic injury, then you can have like a type of adductor longus tendinopathy. Some people advocate that it's adductor brevis. They used to call it the Gracili syndrome before, etc. From my experience, the huge majority of patients have adductor longus related problems. On the other side, in the inguinal canal, it's much more like insidious, slow onset of the injury. And what we have here is in the inguinal canal, the way the muscles work, you have the external oblique, which is like the first layer, and it has the opening of the external inguinal ring. And then below you have the internal oblique and transversus, and they form an arc above the spermatic cord in the inguinal, like from the roof of the inguinal canal, and they insert with the rectus abdominis on the pubic bone. So sometimes the insertion is a little higher, and then these muscles, when you have abdominal straining, instead of going down and protecting the posterior wall, if they're inserted a little bit higher, they cannot protect completely the posterior wall, and then all the pressure that you have from the inside goes through this bare area of the posterior wall of the inguinal canal, and that can cause some weakness and bulging, and this can compress some nerves. This is one of the theories. The other theory can be that there's, because of not enough strength and not enough control in the movement of the muscles, you can have some like a chronic muscle injury or chronic tendinopathy, etc. And then maybe the surgery helps just with suturing, going with the needle through the muscle,
Yeah.
It's some kind of PRP, natural PRP theory, treatment, that you have some bleeding with the needle, and this helps the healing with, of course, reinforcing the wall. So sometimes you can see that the muscles are a little bit harder. They feel like a little bit fibrotic, like something like something chronic going there on there. Are there maybe some chemical mediators, inflammatory mediators? We don't know in this area. Maybe it's like a chronic inflammatory process, and this is affecting the nerves, and that's why you have pain. So is it the pressure from the posterior wall on the nerves, or is it some chemical
we don't
stimuli?
know, is it the chicken or the egg? So
exactly.
Maybe it's the pain causing a spasm, or
exactly, but there could be both, because we can see that a lot of people have wide who have inguinal pain. They have wide inguinal external internal rings, and they have a little pain on palpation, and they have pain on the cough impulse, and you can feel a little bit of bulging. It's like almost like a beginning of a direct hernia. And I wouldn't be sure that if these people were not athletes and didn't have these strains, maybe in the future they would develop a direct hernia.
Mm-hmm. So can we, let's say, can we screen for potential athletes who can develop?
It has been proven through papers that the major risk factors for groin injuries are previous groin injury, number one, and adductor weakness. Number two. This is a huge significant difference. Also, there was a paper from Canada in ice hockey that also proved that off-season deconditioning contributes a certain factor.
Just abrupt change in activity levels.
Well, if they have a big gap in the season and they don't maintain their fitness, they're a bigger risk of
one quick question. You just said that the adductor weakness could be a potential cause, but previously you said it's the ratio between earlier theories, the ratio between adductors being too strong compared to the abdominal wall.
Yes.
So what's the difference?
What's the difference? From me, I didn't go into detail so much, but I believe, just plain logic, that you need to have all these muscles in some kind of balance. So if the abdominal wall is weak and the adductors are strong, they'll probably pull more.
So you might get more...
on the insertion of the adductor longus, you can have more pain. Maybe with weak adductors, it's more tendon pain, more tendinopathy. But again, you don't have, because of the weakness of muscle, you don't have full control of the kick or whatever.
Yeah, one quick question regarding the inguinal category, let's call it. I developed a couple of years back a symptom of hernia, but didn't get any bulging. And I went to a doctor to check. He put a couple of fingers inside the inguinal canal and said that there's no bulging, there's no opening. But he said that the abdominal wall was weak, and I didn't have any symptoms when I cough and I sneeze or whatever. But when I go in a push-up position, when I develop intra-abdominal pressure, I get a pain. And for example, if I'm lying on my back and I try to keep my lower back flat on the ground, and I try to lift one leg, like a hip flexion, I get symptoms. And basically, he said that since there's no bulging or breaking in a wall or fascia, he said that fascia might become thinner, something like that. And what I did back then is I did a lot of hip flexion. And this is a question I want to come back later. We did a lot of, in quotation mark, lower abdomen exercises, if there is upper or lower abdomen. That's one, a myth or whatever. That's one hot topic. It used to be a hot topic before in strength conditioning. So I did a lot of leg rises. I did some PNF diagonals, so lying on your back, and I did, I put ankle weights, and I did the PNF diagonals across the body, and that hits a little bit of transversals because I need to stabilize the pelvis, and I also engage the adductors, and after some time it calmed down, and I would say it's a little bit returning. So my question is, without going into my particular problems, is the sport hernia, is it okay? So now the synonym with the sport hernia is inguinal problems, right? And what about the one with when you have a bulging and when you don't?
it's again, at the moment we call it sport hernia a misnomer, because there is no hernia per se. There is the weakness of the posterior wall. Sometimes it is true when you operate a patient and you can see that there is a small direct hernia. This is one type of injury. But many times you just see a flat posterior wall, but with some weakness on palpation. So you don't feel, it's like a little bit, one part of this posterior wall is, when you go with your fingers, is a little bit floppy. Maybe in the future, this is just the origin of a future direct hernia. We don't know. But at that moment, you don't have a hernia. So you have, like, maybe this is what you had, like a weak wall, posterior wall. And you can have, if you did the ultrasound, you would see maybe some bulging. That this changes your shape when you strain your abdominal muscles. Probably, if it's not a big, if what we call the shutter mechanism, when the muscles go down to the inguinal ligament and protect the posterior wall, if this defect is not too big, probably you can, with some fitness training, strengthening of the abdominal wall, maybe you can increase the coverage of the posterior wall, the shutter mechanism, and you can have you can treat your pain. But maybe also, like I said before, you have this, maybe this weakness is like a weak soft muscles. Are the reason for this is a chronic injury, chronic small micro trauma of the muscle, and that maybe because of a small pain that impairs the innervation, and the muscle is not contracting properly, and then with strengthening you can get it back,
re-educate it,
and get it back to full power. Now this is all theories. I cannot really say this is the real truth, or if we find this will be like the holy grail of inguinal pain. But my theory also is that I would say, but all you guys from strength and conditioning know much more about this. I would like my patients to try to do more abdominals from the trunk extension position, because when I watch athletes perform, rarely you have bending, flexing your body in sports. It's usually first hyperextension, and then you have this movement like a hyperextension and then trunk flexion, not like a flexion from the straight standing position. This is not a physiological movement in sport. So, and maybe this is a short or longer level of work. Maybe this can change the load of the muscles, and then maybe it can contribute to treatment. I don't know, it's just a theory. It's pretty nice to try just changing one type of abdominal strengthening exercise and see what, maybe there's no difference, but and even if we prove this, we advance in scientific knowledge. So
yeah, let's talk about, you mentioned a little bit the diagnosis or clinical exam procedures. How do we, let's say how can a coach or a physical therapist working in a club quickly make any diagnosis and try to differentiate between different groin-related syndromes? What, like, movement screens can be used? What can be monitored across the season, like physical tests or let's say a groin squeeze, whatever. What can we do to prevent it, and check if something is happening, to make some intervention before it happens?
For me, there's two different kinds of examination. One kind is when you have someone who is already injured and has pain, and then I check him in my office in the clinic. And this, you already have to have a significant level of pain for me to be able to detect it. So what I'm trying to say, in this case, then it's pretty straightforward what we defined until now. So if you have pain on the pubic bone, or pubic symphysis, pubic bone palpation, it's pubic-related groin pain. Then if you have pain on palpation of the inguinal region, it means conjoint tendon, inguinal ligament, pubic tubercle, maybe positive cough impulse, etc. It's inguinal-related groin pain. Then you go to the adductors, you palpate the insertion of the muscle on the pubic bone, the muscle itself, the muscle belly, also not only the adductor longus, sometimes it's pectineus muscle, brevis, gracilis, you check all of this. And then you have resisted contraction tests, like resisted sit-ups, you have resisted hip adduction, you have the squeeze test in different angles, and that can cause pain. Sometimes yes, sometimes no. So the situation, then iliopsoas also, you can palpate the iliopsoas right below the inguinal ligament and sartorius muscle, and especially if you palpate and then have a straight leg raise, you can have pain there. So maybe you had also, in your case, iliopsoas related pain with the inguinal related pain, an overlap of both entries. Yep. Like I said before, you can also palpate the psoas through the abdominal wall. You check for a hip range of motion, flexion, abduction, external rotation test, or flexion, adduction, internal rotation, Fadir and Faber tests, and that they can just tell you that there might be some hip problems, but they're not conclusive. And this is the standardized examination that we do in our clinic. But sometimes you can have an athlete who says, I have pain with playing football or whatever, and comes to my office. I examine him, he doesn't have pain. It doesn't mean that he's lying. It is just it is much less strain what I put in the office than what you have an athlete on the field. So sometimes we can have someone doing recovery, and he has fantastic recovery in physiotherapy, he has no pain in clinical examination, and then we have sport-specific rehabilitation in the last stages when he has full effort, or kicking from full speed, crossing the ball with full speed, etc., or changing direction, then he can feel pain in certain moments. Then maybe you have to do surgery, and many times it helps. And don't ask me why. At the moment, we know it helps. There are theories, but I cannot say for sure this is because of this or that. What I'm trying to say is when you follow the athlete on the field, it's much easier for people involved with the club, because you can see how he moves. You can detect the deficits. In our screening, we do the adduction. If there's a check, if there's any shortening of the adductor muscles, and like fallout knees on lying. So it means like you put both legs in normal abduction. You see how far they can go to the examination table. Yeah. And you can measure the angles, and the theory is that when there is a shortening of the muscle, it's maybe a risk factor for injury. This is something also to be, now there's a study done in Aspetar by our PhD student Andrea Mosler from Australia, and she's following this. And also you can do with dynamometer, handheld dynamometer, you can feel the muscle strength.
The squeeze test, right?
Okay, you can do the squeeze test. You can do it with a dynamometer. If you don't have the dynamometer, you can do it with just plain cheap hypertension cuff, blood pressure monitoring cuff, and see how much they can squeeze. And but also you can see the way the athlete is moving, if he's running properly, if there's any. If there's functional Trendelenburg on the field, if the pelvis is falling when he lifts his leg, the way if the motion of running is proper, of the motion of kicking, if there's too much jerking movement, if he can control the kick with his body, and all these sport elements. This is what we are kind of handicapped in the office, because I don't see this. Probably if I could, you would have more insight into the injury.
That's why you have an integrated model.
Exactly. That's why you have
PTs working in the clubs.
Yes.
That makes a lot of sense. So let's say idea for example, you said that the guys who might be prone to develop these symptoms might have different insertion of the muscles. So what about, let's say you want to buy a player. I'm just talking theoretically. And some clubs actually might do a full body MRI scan, and you're not gonna say, okay, we're not gonna buy you because of your insertion is higher, but you can have a pre and post. For example, something happens, you have something to compare with, right? Can we do let's say ultrasound of the groin area, just to see if the, as you said, maybe some athletes might have different insertions? You can do an ultrasound of the inguinal area, and you can see if there's this bulging of the posterior wall. Yeah, but I'm talking about the healthy guys. Even healthy guys, there's a consensus in the radiology community that
for example, if you take the whole team of athletes, probably half of them will have inguinal bulging and they don't have pain.
Yeah. Now, same with the disc hernia.
Exactly, on the MRI.
Yeah.
So if you do this type of screen, now it would be interesting to do a screen and then follow them for a couple of years and see how many of those develop groin pain or not, and see why. So it's like for the ACL, when we say it's the question of the mechanism of non-injury, because you have someone a lot of people doing the same thing, and 99% don't get injured, and this 1% gets injured. We need to find why. So for now, we found that pre-season adductor weakness is a contributing factor for the adductor-related pain. Probably inguinal or abdominal wall weakness and very strong adductors are the contributing factor for inguinal-related pain, or iliopsoas because it has to do more stabilizing function. But and of course, when we know that the previous groin injury is a risk factor, so when you know that somebody had a groin injury, he needs to have a maintenance strength exercise program for all these muscles involved. So from time to time to do his exercises for, and especially if he feels a little bit of discomfort, not even pain in this area, they need to start communicate with the staff, with the physiotherapist, with the fitness coach, and then manage the load a little bit and start doing their rehabilitation program while continuing training and see if it works. If not, if the pain is still there, then they have to stop training and do only that. So, but it's very important to treat it at the early stage. But in terms of screening, what you said, and you have to buy a multi-million-dollar player, and you do screening, you see he has some bulging or he has some higher insertion of muscle, whatever, this is not going to say you're not going to buy this player, because it can be asymptomatic all his career.
But let's say we need to create a 2x2 table, or it's called confusion matrix in data science. So let's say you said that some of the guys having a weird, let's say, reading weird picture on MRI or ultrasound, but they don't develop symptoms. But can we have guys that actually develop symptoms and don't have those weird readings?
Yes.
So you can have all four combinations.
You can have both, but it's very rare that you have someone with inguinal pain that doesn't resolve with some rehabilitation, and he doesn't have any bulging or wide ring or something like this. On the other hand, probably you can have people who have normal adductors, and then they can develop adductor-related pain.
So you already mentioned that screening for adductor strength, flexibility of the internal external rotators and hip flexor, let's call it abdominal wall stability and control. We can use those exercises as a prehab. Just make sure that we hit those check marks, sort of speaking. Is that similar with return to play protocol? Is that prehab and rehab same?
Probably yes. Of course, in the return to play protocol, you probably address the injured muscles more, all the deficits that you find. But of course, I think it would be a mistake just to focus on these muscles and not. You have to treat the whole patient, the whole athlete, to get him back to the field. Because if you just treat this and you forget some other muscles, then they would be in danger of having an injury. So in the later stage, what I usually tell athletes before going back, I say, we don't want to return you to the point before the injury, because we need to make you better. If you were good at that time, you wouldn't get injured. So we don't want to get you at this point. We need to improve you so you don't come back to us.
Sometimes we used to say that injury is a chance also to hit some different things, maybe work on something else that you neglected, and that actually might be a cause of the injury. So let's say a lower body injury, the athletes can pretty much hit the upper body much more, maybe use some imaging techniques, just to don't forget the skill, and stuff like that. We need to figure out what they can do and not focus on what they can't do. One thing you recently, I don't know if you operated or you helped with an operation with a common friend of ours who works for Aspire, and he said that compared to a rehab done in this region, Croatia and Serbia, that the rehab starts basically right immediately after operation, which is fascinating. So he had assistants or PTs coming right after right after the operation. He was still fuzzy after the anesthesia, yeah, and they did a mobilization, and they already started working on a rehab. And I heard stories here in Serbia, luckily, knock on wood, I didn't have any operations, that the doctors are just rest, or they don't, I would say they don't give a shit, but
it's not only Serbia, it's probably it would be more prevalent doing it like this defensive way. It's an old school type of treating patients, and
go home and recover, basically.
Yeah, and rest, because the thing, you have people who are doing the surgeries and are not really involved in sports, for example, and for them it's just, okay, we will recover. So what's the big deal, 1 month or 2 months?
Yeah, exactly.
It's very important to start from day one, and it's very important to have your surgery to have it done by someone who is also involved in sports, who understands the recovery times, who understands the process. And the first few days are crucial, because if you start moving immediately through some pain, it doesn't matter if you feel a little bit of pain, it will not kill you, but it will help you really speed up your recovery. What can also help, which is nowadays, it should be like a gold standard, but still not implemented everywhere. What you try to do is, whatever is the anesthesia, if you do local anesthesia surgery only on one side, it helps in recovery, because with long-lasting anesthetics, in the first few hours they're not so painful, so you can teach them getting back to walk immediately, and then this helps the recovery.
Rehab.
If we have to do both sides in one act, both inguinal repairs at once, and you do it general anesthesia, for example, I would always use local anesthesia throughout the surgery, and a lot of local after, as much as we can give, because we cannot do both sides in local anesthesia because of the amount of anesthetics that you can give before it becomes toxic. But you can. There is a certain amount that you can give on both sides divided, and I try to give it always. And this we found out this helps in post-operative recovery. They have much less pain initially in the first 12 hours, and that's how they can start their rehab immediately. And then you shouldn't be afraid of some discomfort or pain during the initial phase. It's normal to have some pain after surgery. If the pain is on a VAS scale up to 3-4 out of 10, I wouldn't be worried. The important thing is to monitor pain, and if this pain is not increasing after you increase the amount of movement that you do throughout the day, then I would say that you're on the right track, and just continue.
Keep on going. What are the techniques now used in treating the inguinal, I'll call it hernia?
In terms of surgery?
Yeah, in terms of surgery, what do you, how do you fix that?
In the hernia surgery, if you do, you can have now the common procedures are open non-mesh procedure. The gold standard is shoulder repair, which was developed in Canada, near Toronto, in the Shoulders Institute in the 40s, 50s. So they do, it's like a continuous 4-layer, continuous suture, 2 sutures, 4-layer repair. Then there was the development of different prostheses, the mesh techniques, and now the most commonly used is Liechtenstein procedure, which is just with the mesh you reinforce the posterior wall. It is, you can say, technically less demanding. It can have some risk of mesh-related complications. The risk is, to be honest, very, very low, almost nothing. But if you have an athlete with this rejection of the foreign body or something like this can be a catastrophe. Then Dr. Mušavec, who is also our affiliating surgeon from Munich, she developed a so-called she calls it, because she's very modest, she calls it minimal repair, and I call it the Mušavec repair, because all other procedures are named after someone, so she can also have procedures named after her. Which is, instead of in shoulders repair, you have to open the posterior wall, this fascia transversalis, completely from the internal ring to the pubic tubercle. And she discovered that if you just open it partly, where from the internal ring just on the level where you have this bulging, this weakness of the posterior wall. If you just have a small opening fascia transversalis, and then you do the overlapping procedure, which is technical surgical details, not so interesting for everyone, you can have a faster recovery, and you don't use a mesh, and it's a safe, good procedure. It needs
it's a novel procedure, as you said, or
it's a modification. You can say a modification of the shoulders procedure.
Okay,
but with a bit less tension, and probably this gives a faster recovery. Then you have now also people are using laparoscopy techniques, which can be two types: trans-abdominal peritoneal, which means you go with the instruments inside the abdomen, and then from the inside you open the peritoneum, and then you put the mesh
from
between the peritoneum and the
posterior side, right?
Yes, and then you close the peritoneum, or then later developed the total extraperitoneal technique, where you with the gas, with the balloon, you insufflate the space between the peritoneum and the fascia, so you don't go inside the abdomen. Just before in the preperitoneal space, and then you can make it larger with some gas, with the balloon, and then put a mesh in this place without opening the peritoneum and going inside the abdomen, which is an intact area. So the thing is, all these procedures involve mesh placement. My personal opinion is, if you can do a repair which is with similar results and not using a foreign material like with the mesh, it is true that nowadays we have better meshes which are lightweight, large pore, better integration with the tissue, etc. But still, if there's any chance of having a complication because of the mesh, and I can do something with the suture, I would try it with the suture, and then keep the mesh as the second stage, as a more heavy.
What about the adductor issues, like let's say a tendinopathy?
Again, there you have some people are doing percutaneous adductor brevis tenotomy. Someone is doing adductor longus percutaneous tenotomy. I prefer to do an open procedure, not just a blind cut through with a small incision with the skin and cutting blindly the tendon. I like to make a small incision on the skin, open the area, see what they really need to cut, and it's like you can say it's a similar procedure what sometimes elbow surgeons do on tennis elbow, which is not recovering with any rehabilitation, and you have like a small tenotomy of brachyradialis muscle, just cutting the insertion and pushing it down, and then you have some scarring after, so it's like some type of scar elongation of the tendon, and during this healing time you don't have any more the tension on the insertion on the bone.
So you call it releasing the adductor.
Yes, adductor.
Like
so
that, right?
Releasing of the adductor longus, and so you have to, because the adductor longus on the insertion, it's just above the adductor brevis, and on the point of insertion, when you see the whole muscle, it's not like the Achilles tendon, for example, which is all tendon. Here you have 30% is tendon, and 70% is the muscle. So it's like a triangular tendon, and only on the point of insertion itself there's full tendon, and not the muscle.
If there's a tendinopathy and then you cut, so you basically try to, let's say, jumpstart the rehab circuit.
The thing is, usually it's almost exclusively used for the insertional tendinopathy or adductor-related groin pain, which involves the insertion of the muscle. And then the theory is, because it's pulling on the bone, on the periosteum, and there's pain, chronic pain on palpation, and because of this pain they cannot do any exercise. And if you cannot improve in your exercise, then there's no point. You cannot get the tendon healed. So if you cut the tendon completely, then and move it down a little bit, I think it scars first to the adductor brevis, which is right underneath. And I would compare this to, the exercise when we were kids and somebody says I can do pull-ups on one arm. but he grabs the bar with one arm and grabs the other arm.
Yeah. So it's essentially double arm.
Yeah, basically 2 arms, just you're holding the bar with one arm. So this is the same situation what you have here, because when you cut the adductor longus, push it down, it scars to the adductor brevis. So it still has a function, and then over time, with some scar tissue, it grows back towards the tendon. But you had during this time for the bone to recover, because there's less pulling, almost nothing, and you have some elongation of the muscle, and usually they do good.
What's the prognosis after the both types of surgeries? And I'm talking about high level athletes. What's the prognosis and what's the reoccurrence?
I always say 2 to 3 months. And why? Because of what we discussed at the beginning, because you also need to re-educate and to strengthen all the muscles. A lot of them are really, really good already after 1 month. And then the question is, are you going to reintegrate them on the field and let the coach put them on the field whenever they want after 4 to 6 weeks? Or I prefer to have them in sports-specific rehabilitation and to make sure and do fitness.
They follow our return to play.
And to know when they come back that they are really fully capable of joining the team and not to have the recurrence. So in this way you should hope that there is no recurrence in injuries.
Okay. What about the potential side effects of the surgery? What could be complications? What's in your experience?
With every surgery you can have a complication, but in skilled hands it's even minor complications like some post-operative hematoma or superficial wound infection or something should be below 1% of occurrence. Yeah, of course you should be trained well and not to injure basic elements in this region, like in every other surgery, and shouldn't be. In the skilled hands, it is not.
As soon as you operate, you basically risk something.
Of course, in every surgery, you have to undertake some risks, starting from anesthesia, reaction to medication, whatever. But and again, we don't know. We are all not the same, and some people recover faster, some recover slower. So we can say, in terms of statistics, generally, how the majority of people recover in this period of time. Of course, sometimes things don't go as well as planned, and many athletes for different injuries who had to end up their career, and some other recover from these surgeries and continue playing. So,
just to wrap up this part of the interview regarding the surgery, before we jump to listeners or questions from readers, I posted a Facebook post on my wall and asked for a couple of questions from the readers. So before doing that, what would you say? What's the future in this area? What does future bring? What does future bring?
The future in this area, first, after we start using the same terminology, then the next step is to do more and more scientific studies. It's difficult to do randomized controlled trials in highest level sports, because highest level athletes, they want to be treated in the best possible way, not to undergo scientific studies,
not to be a control subject.
Yes, but you can have, probably with good structured prospective studies, cohort studies, you can have some conclusions and some results. And this is what we need to do, and compare different treatments in terms of physiotherapy. Then we can compare, have real studies comparing different surgical techniques to see if really there's any difference in this. We want to do a study on taking some tissue samples and see if there's any collagen deficiency in this area, in inguinal area especially, because we know that behind hernia pathology there's usually collagen deficiency, and this is why people use mesh reinforcement.
Yeah, because can that collagen, sorry for interrupting, can that be systematic? For example, some guys have a hypermobility syndrome.
It is a systematic. It's a characteristic of your body. So some people have level collagen 1, collagen 3 ratio, which is one is stronger, one is weaker. So you have in the fresh wounds, you have the weaker collagen, and then in mature wounds, you have the scar tissue made of strong collagen. Just
thicker and stronger, stiffer.
So if you have this ratio is not as it should be, and you have more weaker than stronger, maybe there's a difference in like Marfan syndromes or Ehlers-Danlos syndrome related to collagen deficiency. So just a thought was, do we have any collagen deficiency in this area? Are these athletes injured because they're predisposed to injury because of collagen deficiency? This is something that we need to find out. And then maybe in this case we will need to use the mesh repair even for athletes. So it will prove me wrong, but it doesn't matter if it helps science. I'm all in for that. Then we have to do so there's a study going on now, just started in our hospital, comparing the results of first conservative treatment for inguinal repair and see how many of these athletes end up having surgeries. Then you can compare the time for return to play if you have a good study comparing conservative treatment and surgical treatment. One of similar studies was done in Finland already, and a lot of people crossed over to the surgical study, and they proved that surgical repair was getting people faster. But still, we don't know if do you operate someone just to gain 3-4 weeks if he doesn't need surgery. Mm-hmm. That's still a question, a little bit ethical. But on the other hand, if you have someone who needs to get ready for the World Cup, 4 weeks can be crucial.
Yeah, exactly.
So then you don't. Basically, it's not such a big surgery, mutilating surgery, so you can always do it. It's a reinforcement of the wall. You do hernia repairs for babies when they have a small hernia. So it's not something that is a huge surgery and changes your life in any way.
Yeah, a friend of mine has 2 kids, and they already had hernia. So and they were like 3 years old. So they I think they operated them and put this mesh. So what's the cause of that?
Mesh would be for small kids. It would be really.
I don't know. I'm just.
Yeah, maybe.
I'm probably wrong, but what's the reason for that?
The reason is you have how the hernia develops. The scrotum, the testicle comes to the scrotum from the inside the abdomen and goes through with what we call processus vaginalis, which is like a extension of the peritoneum.
Yeah.
And this is what is one of the envelopes of the testicle. So this canal usually obliterates, but in 20% of people it stays patent, it stays open. So this is where you can have internal.
What about the girls? Like these were girls.
Girls, small girls with hernias. That would be more for a question for a pediatric surgeon. But in girls, you have because hernia itself is like a 7-to-1 ratio in favor for men, and but for girls, they usually have femoral hernias. Maybe these girls have a collagen deficiency, what you just mentioned, because you can have. It's
I just mentioned it since you said that it's common also and frequent operation with small babies as well.
It's not so frequent, but it happens. I'm just saying, and people do it, and then babies have normal life. So if you have a grown-up athlete and you need to do surgery, and you are thinking, should I do it or not? Even if you operate, it's not such a big change in the homeopathy of the body or whatever. So it's not that aggressive. You can say a little reinforcement of the muscles, and he continues with his life.
Thanks a lot. Let's continue with a couple of questions from the readers. One question is that why is it seems that there's a increase in these symptoms in elite sports, and what about the pediatric age groups? What's causing it? What are your thoughts about it?
Why is the increase? Maybe it could be different contributing factors. First, maybe we put more. We are recognizing it more and more. Maybe you had people before just ending their career because there was no help and awareness, and we tried to treat it. There's more and more advance in treatment, so people get treated more, and we see more patients. Second, nowadays, with more and more money involved in the sports, every injury becomes more and more significant than before. Third thing, nowadays we know that the highest level athletes are submitted to much more workload and more games than before, more matches and less recovery time. So this can be one of the factors. And about the pediatric age group, we just also came to a theory. It's after work from our colleague Matthew Sally, who worked in Aspire Academy as a Aspire physician, that in pediatric age group, adductor-related groin pain, especially insertional pain, is almost similar to different teenage apophysitis problems, and like Osgood-Schlatter or similar, and that instead of loading the tendon for healing, you have to have a different approach. You have to rest the tendon. In this case, you need rest because it's not the tendon problem, it's the apophysis. It's where the bone grows, the growth plate, and due to stress, it doesn't close properly, and it's there's like an inflammatory response, and this is what is causing pain. So in this case, because it's not the tendon which is the problem, if the problem is the bone, then you need to rest. So, and it's very important to know that the pubic bone apophysis, where the adductors insert, are the almost last ones to close, to fuse completely. So they can be open until 23, even in some cases 25 years of age. So whenever you have an athlete who is 21, 22, and you do exercise treatment and he doesn't get better, and
you need to check for that.
And you of course, we do an X-ray for all athletes. In the 99.9% it would be unremarkable, but I would never want to treat someone and then end up having someone with a tumor, a silent tumor, and you treated him for a tendinopathy. So, and one X-ray is not too much radiation, so it's not a big deal.
You need to get that off the list.
Exactly. So you do an X-ray of pelvis and both hips, and you see if there's any FAA impingement, and you see if there's any changes on the bones. And then, of course, you can do ultrasound, which is also not expensive and very much available for everyone. And you can check the adductor tendons, you can check the bulging in the inguinal canal, and then if something's not going like in the way you would like, you can always do an MRI, which shows the muscles move better, and especially you can see the iliopsoas muscles also, the adductors, and even the inguinal canal and the pubic bone stress, etc. So this is about when we talk about imaging. So when you do imaging, you can see that the apophysis, if they're not closed, maybe give them, if there's especially younger than 20, just give them rest. It's a different approach because, and I would never fight for a junior athlete to get back in 2 or 3 months. Give him over 6 months to come back because you don't want to ruin his career.
Yeah, exactly. Short-term versus long-term goal.
Exactly.
Yeah. Stefan asked a question about the connection between breathing patterns and deep pelvis tissues, and if the breathing is related to that. And he also mentioned if there's relationship between that, the breathing, and discus hernias and sacrolumbar area issues.
Okay, breathing I think is important. In which terms, I read a paper. It's difficult. I cannot remember at the moment the author, but the paper was about the involvement of different abdominal muscles in different maneuvers, you can say, and you can see that they did an EMG study, muscle activation analysis, and you can see that there's a different muscle activation in terms of when you draw in, like doing a core stability exercise, or when you go to the toilet and you have defecation, and where you also have muscles training in the abdomen, but there's different types of activation. What I'm trying to say is
bracing.
Yes, the abdominal wall is not only the abdominal muscles, what we call the core is also the diaphragm, which is if you look at the core, the abdomen as a box, you have the roof is the diaphragm, and you have the pelvic muscles as the floor. Yeah. And then you have the anterior muscles, like rectus abdominis, then you have the lateral muscles, which are the obliques, and then you have the posterior wall with iliopsoas, and then the quadratus lumborum and the other muscles, multifidus, which is also very important. So is a discus hernia related to groin pain. Discus hernia or some kind of low back pain can be related because if it impairs the activation of the multifidus muscle, is it so significant for pelvic stability? If it is, then it can be like a vicious circle, a little bit of imperative one muscle affecting the other muscles, and then you don't have the contraction of the lateral abdominal wall. And you always have to remember that the lateral abdominal wall goes from the back and forward towards the rectus abdominis and inserts on the pubic tubercle. So you can have inguinal-related groin pain starting from this. Also, sacroiliac joint it's a good point, can be related to the cause of pain, because if you have a little bit of restriction in mobility of the sacroiliac joint, it is what Professor Myers in his work and also Dr. Kugat are advocating, that you have the concept of the pelvic joint, which is the pubic symphysis anteriorly and the sacroiliac joints posteriorly. So the whole pelvic complex of bones is like the pelvic joint with these three joint surfaces, which are very you have very small movement in these joints, but they have to have this 1 to 3 degree of freedom. Otherwise, if they're stiff, that stiffness can probably relate to some other muscle impairment and muscle activation patterns, and then you can have
I think a lot of people or athletes that complain about low back pain might have sacroiliac issues, not only low back problems, but that's probably another story. Armando asked about the lymphatic and lower body circulatory problems, also visceral dysfunctions, nutrition, and weight in groin-related pain. So I think this is more holistic question.
Yeah, it's of course. I mean, when you talk about that, do we talk about general population or we talk about athletes? If we talk about athletes, then you shouldn't have overweight athletes, and you should have people who have enough rest, who have proper nutrition, and then these things should be out of question. Should be young people with good arteries. If you have a healthy lifestyle, no smoking, they're not diabetic, etc., it doesn't affect the arteries. Lymph drainage, I wouldn't be an expert on this topic. Maybe it has something to do with it, but this is more for massage experts to see if with massage and enhancing lymph drainage you can add up to recovery, and then probably if you can speed up the recovery time, probably you can do, it's like a prevention treatment for many injuries, including the groin injury. But like I said, for a sacroiliac joint and this small degree of freedom that is necessary, it's probably not so important for a normal person. But for an athlete who has 1 million repetitions of every movement, and if it's not a perfect movement, if it's a little bit of restriction, if it accumulates, if you multiply with the number of repetitions, then it's not a small degree, it's a huge degree of dysfunction.
It's like comparing a Honda Civic and a Ferrari. So if you have a small imbalance in chassis in Honda Civic, it doesn't matter because the velocities you reach are low compared to a racing car or Ferrari. So if
you put a Ferrari engine in the Honda Civic,
it's gonna blow up,
or maybe you end up out of the road.
Yeah, exactly. So last question from Brian, and I think we already answered his first question. Is training options for general health and function in those regions? As you said, mostly adductor strength. Flexibility.
For me, core stability. Core stability, I think, is with whatever sport you play. Core stability is like, I would be like a priest advocating core stability, because when you look at the kinematic chain in any sport, if it's throwing, if it's kicking the ball, if it's
everything goes through
like a basketball with a jump shot, you have to have a core stability to facilitate this. Otherwise, you'll always have a weak link that is going through the...
Speaking of that, and I'll come back to Brian. Brian's second part of the question is that we usually train the core when you are relaxed. You know, everything is nice. We can play some nice music in the gym when we do those active recovery sessions or whatever. But we usually don't train the core when we are breathing heavily, when you're tired. So breathing heavily and then doing some core exercises might re-educate, because you don't want to see those, when you breathe, you don't want to see those fluctuations in activity of the muscles. So, we might, as a strength conditioning coaches, we might try to do those, I would say, in a more challenging environment when you're tired, when you're breathing heavily. So let's say instead of just doing core exercises when you're, warming up and, in a cool down, we might inject those exercises. Let's say when you play a small-sided game, you're breathing heavily, you're in a contact, then we can, do those when you are actually tired. So then you need to control when you are tired. So
I think it's a very nice concept, because probably the majority of injuries, any kind of injury, happens during near the end of the game. Because, and if anybody played any sport, you know from yourself that once you're tired, your reasoning is not good enough, and then and you shoot instead of passing, and just to finish the action faster. And because if you're not thinking properly, your reaction time is slower, and not only reaction time in terms of skill demands for the game, it's also reaction time in terms of micro adjustments in the body,
activating some muscles.
So probably you get more ACL injuries near the end of the game when the muscles are tired, and then they don't correct the dangerous positions as soon as they need to. Probably in the groin pain, you have these micro trauma episodes, and if you don't activate all the muscles in the right way, especially like you said, it's a good plan. If you train this when you are tired and you're breathing heavily, but you still maintain your core stability, this will reflect on the game, and then at the end of the game, when you're breathing heavily, your core will still function, and then you wouldn't have these jerking movements, small jerking movements in the muscle attachments where you have a micro trauma. That
makes sense. The last part of the Brian question, and we're gonna finish up with this, is treatment options for deep hip flexor calcific, can't even read, deep hip flexor calcific tendinosis.
It's a iliopsoas calcification. That's more for an orthopedic surgeon. I would consult a hip surgeon for this, but first you try with whatever treatment modality you can do. I can relate this to sometimes you have in the shoulder supraspinatus calcifications, and when you see these calcifications on the X-ray, you think it's like almost like a stone, something very hard. But during surgery, sometimes when you just with needle, when you open the tendon, it's just like some powder that goes away. And probably with the advance of hypertroscopy, you can reach these muscles, and after failed conservative treatment, if nothing else works, with deep tissue massage, pressure treatment, dry needling, whatever you can do, and if nothing works, then you can try with hip surgery, laparoscopic hip surgery to reach they can do it sometimes. You can even do, some people did tenotomy of the iliopsoas muscles in terms of severe hip contractures. This is a different thing, not related to sport. But to be honest, I wouldn't attempt any surgery on the iliopsoas muscle unless we really did an extensive conservative treatment program, and if it really affects the quality of life and the performance, and there's nothing else you can do, and you have to do something, then maybe you would, and you have the validation of the calcification on the X-ray and or MRI, then you would probably have to do something. Sometimes you can also do a peritendinous cortisone injection, because also sometimes you can have a iliopsoas bursitis and an inflamed bursa that doesn't resolve with conservative treatment, and you do a cortisone injection and it might help. But of course, like with all cortisone injections, you have to be very careful. It can be short-term relief of pain, and the worst thing that people can do is after cortisone injection, because the pain goes away, to start training immediately. It should be utilized just as a mean to facilitate rehabilitation and physiotherapy exercises, but not to go to reduce the pain, then go and play, because then you just have a bigger problem after when
it worse.
Yeah.
You mentioned, and I'm just going to quickly ask you about this deep tissue massage. There are some treatments, especially in track and field. They have a massage therapist on the track, and he's doing usually a pre-track workout massage, or I don't know how they call it. They call it a track masseur or track therapist, and sometimes they do a deep tissue massage, and they call it a psoas release. So how smart is that, and what are you actually affecting? Like, can you actually affect the now we have this fascia is like a hot topic at the moment, and everybody's talking about fascial trains and Myers and deep tissue massage and fascial releases and self myofascial releases. And how can we, are we actually affecting the fascia with the massage or foam rolling or whatever?
It's more a question for an expert in physiotherapy, but I would answer this with another comment. First, if you never did something, I wouldn't try it on during the competition.
Yeah, exactly. You don't wear new shoes on competition.
Exactly. Second thing, if you have an athlete who has short hip flexors or shortened hamstrings, very tight, etc., but he's 28 years old and had his career already playing since he was a kid and never was injured, and now a new hot physiotherapist comes and screens everyone, says, oh, but you have short muscles, now we'll correct this, and then maybe you put him into a risk of injury, because if he's 28 or 30, why would you correct something that doesn't give any problem?
Don't correct if it's not broken.
Exactly. So that's something, like I said, I can just discuss this through general medical and sports knowledge, but it should be, it's a hot topic between physiotherapists. If you have normal muscles and then you have before the competition pain, and then there's a shortened muscle and you need to do something, probably there are ways to release it, but just as a form of treatment, not less as a form of doing for everyone. And
yeah, exactly. We're gonna finish up with that one. Last question, just general question, is where can coaches and athletes find more information about you, and where they can also find more information about the topics we mentioned, and if you have any good sources you can suggest to applied settings, coaches and physical therapists working in the field.
I would just say we have in Aspetar, we have our Aspetar journal, which is we have 4 editions,
and it's free, I think, right?
Free of charge, and you have it free online. So you just go to Aspetar website, you'll find the link to the journal, and then you have all the interviews and all the papers written, which are more not scientific papers, it's more for general population.
It's more applied, yes.
Applied papers from high-level experts in different topics. And I think it's something very interesting for every sports and healthcare professional working in sports. And if we talk, and there was also one. Sometimes we have targeted topic editions of us, but aside from these 4 Aspetar journals, and then you have different articles discussing only one problem. And we had one about groin pain.
Editorial, is it called editorial?
It's targeted topic journal. So editorial is the thing that they write at the beginning, but it's targeted topic groin pain, or targeted topic tennis injuries, or whatever. So and you can find it on the Aspetar website, and also on YouTube. You have Aspetar YouTube channel, yeah. And you can find, just type Aspetar Groin Pain Conference 2014 on YouTube. You can find almost all the lectures that we had during 3 days of conference, again with high-level experts.
Yeah, I'll make sure to post those links on our website. Anyway, we are. I want to thank Žarko for giving us some of his free time. We are currently here in Belgrade, in a Zvezdara forest. You can hear some kids screaming and maybe some cars passing by, some flies or birds. Sorry about that, but it's a great ambient to talk about these topics. Anyway, I want to thank Žarko for all this insightful information and for his time. Thanks a lot. I'm pretty sure the listeners learn a couple of things and they enjoyed the interview. Thanks a lot.
Thank you very much, and I'm happy that we have so many people interested in this topic. I think working together, all of us, strength and conditioning experts, physiotherapists, sports medicine doctors, general surgeons, orthopedic surgeons, we can, and involving athletes with their experiences, we can reach some conclusions and have some more scientific studies from different, looking at the problem from different angles, and I'm really looking forward to this. Thank you very much for your interest, and it was a pleasure to share my time with you.